Hi, my name is Giselle Avalos, and today I will be presenting on the infectious disease I have been studying this semester, shigellosis. Just to give a brief description in case you have never heard of this infectious disease, shigellosis is an infection of the intestines and gastrointestinal tract, leading to similar symptoms of or to food poisoning. So here's an introduction to shigellosis. So the formal name for shigellosis is bacillary dysentery. Some common names are Shigella gastroenteritis, Shigella enteritis, Shigella infection, and Marlowe syndrome. Three common nicknames are traveler's disease, daycare diarrhea, and dysentery. And the origin of all these names derive from the bacterium Shigella, which is the infectious agent, which I will get into in the next slide. This was first discovered in 1897. The term Shiga honors Dr. Kiyoshi Shiga, who discovered the disease, and the bacteria are named after him due to their association with dysentery and other gastrointestinal infections. So the infectious agent of this disease is the Shigella bacteria, and four species of Shigella are Shigella sone, Shigella flexneri, Shigella boydii, and Shigella dysentery, specifically type 1. Shigella is part of the Enterobacteriaceae family within the class Gamma-Proteobacteria and the phylum Pseudomonadota. So Shigella are rod-shaped, non-motile, obligatory anaerobe, non-spore-forming bacteria. Shigella have a typical gram-negative cell wall that includes lipopolysaccharide. They are tolerant to low pH environments and are genetically related to Escherichia coli. Like their Enterobacteriaceae family, they express an O antigen. While they are closely related to E. coli, Shigella strains are also less active in carbohydrate utilization and are among the oldest human-specific pathogens. So before I speak on the different strains of Shigella, I wanted to give you a side note of what Shigella toxin is. Shigella toxin, also known as Shiga toxin, is a potent bacterial exotoxin that is primarily produced by one of the notable strains Shigella dysentery, and also present in some of the serogroups of E. coli. This exotoxin is responsible for severe gastrointestinal diseases. The first notable strain is S. flexneri. S. flexneri is a strain of Shigella that produces SHET1 and SHET2 enterotoxins, contributing to watery and bloody diarrhea. This strain is most common in low and middle income countries. The second strain is S. sone. This is a Shigella strain that accounts for over 2/3 of shigellosis in the US, and it usually causes milder illness but can still produce Shiga toxin in some cases. The third strain is S. dysentery. This strain is the only strain that causes large-scale outbreaks. It produces Shiga toxin linked to the hemolytic uremic syndrome, also known as HUS, and severe complications. It is the most common cause of shigellosis in the US, and it has the highest fatality rate of up to 10%. Lastly, S. boydii is a Shigella strain that is rare in the US, but remains significant in areas with less access to resources. So all these strains of shigellosis are pathogenic, but their virulence varies. So Shigella was discovered following a bacillary dysentery outbreak in Japan in 1896. Shigella was then adopted as a genus with 4 species in the 1950s. The Shigella germ was first discovered in 1897 by Dr. Kiyoshi Shiga, in which the term Shiga honors. The disease affected military operations and troop deployments, and scientists working at Walter Reed Armour Institute of Research had been trying to make a vaccine. This pursuit of a vaccine was then continued by the U.S. Army, and in the 2000s, genetic studies showed that Shigella was closely related to E. coli. Its pathology. So shigellosis is an infection of the colon, so the intestinal epithelium is affected. Enterocytes and M cells in the intestinal lining are affected. Rarely, Shigella bacteria affects other parts of the body far from the digestive tract, but in severe cases it can lead to kidney failure. Joint pain and central nervous system interruptions can occur, such as confusion or seizures, which are particularly seen in children. So now I want to speak on its modes of transmission. So Shigella germs are spread easily from person to person, and it only takes a small amount to make someone sick. Humans are the only host of Shigella, and it is primarily spread through the fecal-oral route. Shigella germs are transmitted through direct contact with an infected person's feces, So, for example, after changing a diaper of a sick child or touching the surface with contaminated germs from the poop, then touching your face and your mouth without washing your hands is how you will get infected with this bacteria. The 5Fs is a great acronym for how Shigella is transmitted. This is through food, by eating food that was prepared by someone infected by Shigellosis, or eating fruits and vegetables grown in fields that contain the contaminated or contain the germ. Drinking water contaminated with feces is another way for transmission of Shigella germs to occur. Right here in the bottom left is contaminated water. Other routes of transmission are flies, especially houseflies, because they are drawn to human feces and other decaying matter, where Shigella bacteria specifically thrive. The fly can pick up Shigella bacteria from infected feces and then land and transfer them to food, utensils, or surfaces. Fomites are also another mode of transmission, such as taps and toilet seats. And then your fingers and feces, obviously, because your hands touch everything, and if you don't wash them, that is how you will continue to spread. Sexual intercourse is also another way for shigellosis to be transmitted, which is often only seen in gay or bisexual men. So here is the pathogenesis and metabolic pathways of shigellosis. So shigellosis expresses type 3 secretion. It acts like a syringe to inject bacterial effector proteins into the host epithelial cells, and this mechanism is found in all 4 of the species that I've mentioned. So as you can see in this image here, it's showing that it's using the T3SS type 3 secretion system to inject its effector proteins into the cell. So virulence factors include Shiga toxins, which I mentioned earlier, AB toxins, which are primarily found in Shigella dysentery type 1. This functions as a 2-part toxin where the B subunit binds to host cell receptors and the A subunit inhibits protein synthesis. In this image, you do not see the A and B subunits, but you can see how the Shiga toxins kind of work, how they kind of formulate. Biofilm production is another mechanism that is observed in S. sonnei and S. flexneri under environmental stress. The function is a bacterial community encased in a protective matrix that enhances the survival of this bacteria on surfaces and in water. It also increases the resistance to antibiotics and host defenses. Ipoproteins mediate invasion and escape from phagosomes. This is found in, as well as all the pathogenic Shigella species. Actin-based motility hijacks host actin to move intracellularly, and this mechanism is found in S. flexneri strains. The T3SS and Ipo proteins allow Shigella to colonize, invade, and replicate inside colonic epithelial cells. These virulence mechanisms can also cause cell death and cytokine release, leading to major inflammation. So here, these little tails at the end of the Shigella bacteria, that's the actin that's pushing it into the next cell laterally. Okay. I mentioned that Shigella species have tolerance to low pH environments, which enables the Shigellas to transit the harsh environment of the stomach. So that's why they're able to live in the stomach or inside the intestinal tract. The major metabolic pathway that allows shigellosis to thrive involves RAC1 wave ARP23 pathway. I am not sure if that's how you actually say that, but that's how I'm going to say it. During basolateral entry into the host cell cytoplasm, Shigella delivers a subset of effectors into the host cells through the T3SS, or the type 3 secretion system. The effectors induce membrane ruffling through the stimulation of this metabolic pathway, enabling the bacterial entry into the epithelial cells. This pathway facilitates the spread of bacteria within the intestinal epithelium, and an important effector of this metabolic pathway is VRG, which induces actin polymerization at one pole of bacteria, allowing bacteria to spread and infect adjacent cells. So that's why they are is going sideways, or spreading in a sideways direction. OSPF, OSPG, and IPA-H are also important effectors because they downregulate the production of pro-inflammatory cytokines. helping bacteria circumvent the innate immune response. So on this slide is kind of just like the same thing I talked about in the last one, because I know the last slide had a lot of information. So first, Shigella are taken up by the M cells and transported beneath the epithelium. The macrophages take up the Shigellas, the macrophages die, and then they release the bacteria. The bacteria enter the inferior and lateral aspects of the epithelial cells by inducing endocytosis. The endosomes are quickly lysed, leaving Shigellas free in the cytoplasm, as you can see here. I guess step 3 of this process, actin filaments quickly form and push the Shigellas into the next cell. So these little, little small V-looking things coming out of the Shigella germ is the actin pushing it to the adjacent cell. Fourthly, Shigella multiply in the cytoplasm and infection spread to the next cell. So now there's just multiple actin filaments growing at the ends of the Shigella, pushing them. And then lastly, infected cells die and slow off. The intense response of the inflammatory cells begin the neutrophils, and bleeding and abscess form. And this is the same image from the last slide. The immune response in shigellosis involves both cellular and humoral immunity. Cellular immunity is crucial as Shigella remains an intracellular pathogen targeting the epithelial tissue in the colon and causing inflammation. The humoral immunity is also activated with B lymphocytes responding to the antigens by phagocytes, leading to the production of antibodies. The specific antigens detected during immune response include those from the Shigella bacteria, which are presented on the surface of the infected cells. So the incubation period for shigellosis is typically 1 to 4 days. This can vary from as short as 12 hours to 7 days, depending on the specific serotype of Shigella involved. People who have become infected with shigellosis begin experiencing symptoms 1 to 2 days after contact with Shigella bacteria. Symptoms will usually last 5 to 7 days, but some people can experience them from a few days to 4 or more weeks, and in severe cases, it will take months before bowel habits return to normal. Common symptoms include diarrhea, fever, stomach pain, malaise, which is just a general feeling of discomfort or illness or fatigue without a clear cause, and the feeling to need to pass a stool. The feeling of needing to pass a stool even when the bowels are empty is also another symptom, and people may also be asymptomatic. In severe cases, bloody diarrhea and bloodstream infections can occur. Rarely does Shigella ever enter the bloodstream, but it is possible, especially when they do so much damage to the intestinal lining that they do enter the bloodstream. This occurs particularly in individuals with weakened immune systems, such as those with HIV, diabetes, cancer, or severe malnutrition. Reactive arthritis can occur after the infection. Seizures have been reported among young children with shigellosis, and there are currently no explanation for why the seizures occur. Shigella flexneri will cause a person to experience reactive arthritis after the infection. Some other common, effects after infection include joint pain, eye irritation, and painful urination. Hemolytic uremic syndrome, HUS, is a rare complication of shigellosis, which is most commonly occurring in children. HUS is caused by the Shigella dysentery type 1 bacteria. HUS occurs when the Shigella bacteria enters the digestive system and produces toxins that destroy red blood cells, blocking kidney filtering functions, which lead to kidney failure. Patients with HUS often have bloody diarrhea. HUS can also occur with antimicrobial resistant drugs. Can occur when antimicrobial resistant drugs are used to treat the infection, or when treatment is started after 4 days of symptoms. This is a leading cause of death in S. dysentery outbreaks, and HUS is a significant concern during outbreaks. Diagnosis methods are often laboratory tests due to the symptoms of shigellosis being the same as other diseases. Stool sample testing is the gold standard for diagnosis. Cultural independent diagnostic testing is a test that can detect the presence of Shigella without needing culture. This is most effective when culture is not available or when a culture test is positive but the patient is not responding to the treatment. Antibiotic sensitivity tests are performed to determine when antibiotics are effective against a specific Shigella strain. PCR is highly sensitive and a specific test that can detect Shigella in stool samples. It is particularly used when used or useful during outbreaks or in cases where culture is not available. Genetic fingerprinting techniques like pulsed field gel electrophoresis can help characterize Shigella isolates, aiding in outbreak investigation and public health surveillance. So shigellosis typically resolves itself after 5 to 7 days without antibiotic treatment. Antibiotics may be prescribed to people with severe cases of shigellosis to help them get better faster, but some antibiotics are not effective against certain types of Shigella. Ciprofloxacin and azithromycin are two recommended oral antibiotics. There is currently no vaccine for shigellosis, but the process of producing one is underway. Prioritizing clean water supply will significantly reduce shigellosis because it is spread via fecal-oral route, often through contaminated water and food. Hygiene or practicing good hygiene, such as hand washing after using the restroom or hand washing after changing a diaper, possibly before eating and preparing food after doing those things, would help prevent getting shigellosis. Public health campaigns such as promoting hand washing, sanitation, and safe food handling would be beneficial since these practices have been effective in reducing outbreaks, especially in childcare settings, because younger children do touch things, especially when they go to the restrooms, and oftentimes they aren't able to wash their hands correctly, so they may still have really dirty hands. So the CDC estimates that about 450,000 cases of shigellosis occur in the U.S. every year, in which about 242,000 of these reported cases are infections that are antimicrobial resistant, leading to 5,400 hospitalizations and 38 deaths. These are all approximate numbers on reported cases, so the numbers could actually be higher. Worldwide, there is an estimated number of about 80 to 165 million cases and 600,000 deaths yearly. Shigellosis is a leading cause of death in certain subpopulations, especially in young children, but it also affects the overall population. There has not been a pandemic of shigellosis, but shigellosis is endemic in many parts of the world. Some regions where this disease is endemic are in the sub-Saharan Africa, South Asia, and Latin America, because these are developing countries containing a dense population in certain areas where there is poor sanitation and poor personal hygiene, as well as contaminated food and water. So here's some recent information on shigellosis. There have been 8 outbreaks of shigellosis in the U.S. between the years 2000 and 2015. In Oregon, there had been 40 new cases reported on shigellosis since January 2025, with the outbreak linked to a strain introduced in spring of 2024. This information is particularly directed toward gay and bisexual men, which I will explain in a short moment. So, shigellosis is a disease that anyone is able to receive, but there are some groups of people that are more likely to get sick with shigellosis than others. Children younger than about 5 years of age are the most likely to become infected with shigellosis because of the many outbreaks that occur in early childcare and education settings. Travelers who are going to places where food and water may be unsafe and where sanitation is poor are also most likely to become infected with shigellosis. Travelers often become sick with the types of Shigella that are more difficult to treat and like the more severe cases. And gay and bisexual and other men who have sex with men have factors that put them at increased risk for shigellosis compared to other groups who present sexual activity involving stool exposure. So that's why the recent information is more portrayed towards those group of men just because of some of the activities that they partake in. People who are experiencing homelessness are also at high risk for Shigella infection, where there's shigellosis spread in their community. their living situations are what put them at the increased risk for disease transmission. So here's the future outlook since there is not currently a vaccine. So the concern regarding shigellosis is primarily due to the increasing prevalence of extensively drug-resistant strain, known as XDR strains. These XDR Shigella strains pose a public health challenge as they are resistant to all commonly recommended antibiotics, such as azithromycin, ciprofloxacin, trimethoprim, sulfamethoxyl, I'm not sure, just butchered that name, and ampicillin. Antimicrobial treatment may be indicated to prevent further complications or shorten the duration of the illness while antibiotic treatment is developed. Some prevention measures that have been implemented are giving those with weak immune systems oral zinc supplementations and the continuous improvement for clean water sanitation and hygiene development in low resource settings. Most importantly, the efforts for the development of a vaccine against shigellosis have been renewed now that there's an increased knowledge of the Shigella's immunopathogenesis and its continued widespread disease impact and rising antimicrobial resistance. So research is being done on trying to get this vaccine out. Here are the sources that I used for this presentation, and I hope that you enjoyed. Thank you.